Good afternoon and welcome to this webinar. Thank you for joining us. My name is Renee Peck-Mazaris and I'm Vice President for Community Health and Health Services Research at North Shore Long Island Jewish Health System. By training, I am an applied research psychologist and I've been working as a health services researcher in the field of healthcare for the past 25 years. I study what works in healthcare, with whom and under what conditions, and I'm the author of 28 articles in peer-reviewed journals. I'm Associate Professor of Population Health at the Hofstra North Shore LIJ School of Medicine, and I serve as faculty for the Masters in Public Health at Hofstra. I'll be talking with you today about the use of telehealth self-management in managing heart failure in community-dwelling seniors. We're going to ask you to hold all questions until the end, and we'll get to all questions. Okay, so let's start with some definitions. What is telehealth? Telehealth is the delivery of health-related services and information via telecommunication technology. It can be as simple as two professionals discussing a case over the telephone, or as sophisticated as conducting robotic surgery between facilities at different ends of the globe. Telehealth is an expansion of telemedicine, which more narrowly focuses on the curing of a disease. Telehealth encompasses prevention, promotion, and cure. One of the biggest areas of telehealth usage is the home monitoring of conditions by patients that have chronic illnesses. There are many different studies showing a lot of variation of the impact of this technology, and I personally am of the opinion that the details are very important. As they say, the devil is in the details. I've served as principal investigator of 3 telehealth studies over the past 3 years, and I believe that how often you monitor the patient, how involved the patient is in his or her care, the sophistication of the technology, all, in my opinion, makes a difference. So why are we studying heart failure? Well, first, heart failure affects nearly 5.7 million Americans. It's responsible for more hospitalizations than all forms of cancer combined. It's the #1 cause for hospitalization among Medicare patients. And in 2008, the estimated total cost of heart failure in the United States alone was $37.2 billion. We have a number of challenges in heart failure. The first challenge is physical, changes that occur in the body. The second challenge is how we manage them. In terms of physical changes, heart failure, like most chronic diseases, is progressive in nature. A patient can be in stage 1 of heart failure, where physical activity does not cause undue fatigue, palpitation, or shortness of breath. And it does progress to stage 4, where the patient is unable to carry out physical activity without discomfort, and even has symptoms of cardiac insufficiency at rest when they're laying down. Heart failure usually develops slowly as the heart muscle weakens and needs to work harder to keep blood flow flowing throughout the body. There are many different conditions that can lead to heart failure, including a previous heart attack, high blood pressure, and coronary artery disease. Any of these can prevent the heart from efficiently pumping blood to the rest of the body. A healthy heart beats 60 to 100 times a minute, providing oxygen-rich blood to the rest of the body. The lower left chamber of the heart, called the left ventricle, is the main pumping chamber. When a patient has heart failure, the heart may beat faster and the ventricle may increase in size, becoming a less efficient pump. When the kidneys sense this reduced blood flow, they attempt to compensate by retaining more water and more salt. This excess fluid retention often causes congestion in the tissues, swelling, and increased strain on an already weakened heart. So, these physical changes that I just described cause the patient to have symptoms that worsen, often resulting in a hospital admission, and the literature tells us over and over again that hospitals are not good places to be, especially for older adults with compromised immune systems, where they can be exposed to many people with different infections. In fact, it's been shown that hospitalization of the older adult often results in a loss of functional status. So unless it's absolutely necessary, hospitalization of the frail older adult should be avoided at all costs. But it seems we have an opportunity here. What you're looking at here are physical changes, what happens to a patient before hospital admission that has congestive heart failure. If you see, the first bullet says that 98% of patients have dyspnea within 8 days before hospital admission. 77% have edema within 12 days of hospital admission. And 41% have weight gain within 11 days for hospital admission. This pattern suggests that there is a time window between symptom exacerbation and hospital admission during which earlier access and intervention might prevent hospitalization of these patients. So there seems to be a real opportunity here to address the physical challenges, which is our first problem. Our second problem is the way that we manage the patient, and allow me to illustrate. At the lower left, you see the patient is home. Patient is home, doing okay. They start to exacerbate. They call their primary care doctor and say, I can't breathe, I'm short of breath. And what do they tell them? Go to the emergency room. At which case the patient goes to the emergency room and is most often hospitalized for the exacerbation. They then are discharged to rehabilitation or home care, and then they are stabilized once they're in home care. And once they are stable, they're discharged. So we remove everything at that point. The patient no longer is receiving services except for the occasional primary care visit or the visit to a cardiologist. We clearly need to, unfortunately, this is the cycle that Medicare pays for. It's extremely inefficient, it's extremely costly, and we clearly need to develop a new paradigm for caring for older adults with chronic care conditions. We believe that better chronic care management is necessary to improve quality of life for older adults. We know that proper management, including food choices and medication management, not only helps the patient feel better, but also significantly slows the progression of the disease, which is good news for the patients. What we're trying to do here at this red arrow is to intervene. With the support of federal, state, and private foundation funding, we're trying to break this cycle by intervening here with telehealth at home. So when the patients come off of home care, they receive telehealth. And it sort of continues their home care. Through telehealth monitoring, we think we can cost-effectively provide care, educate, and monitor the patient at home. So the patient can talk to the clinician can see the medications the patient is taking, listen to the patient's heart and lung sounds through a stethoscope, which you'll see in a minute, monitor wounds, do almost anything you can do in a live visit except physically touch the patient. At the same time, the patient is charged with reviewing and sending their own vital signs, empowering the patient and involving them in their condition and giving them the tools to manage their disease. Our first two research studies, supported by the New York State Department of Health and private foundation funding, was just published in Telemedicine and eHealth in March. Our results were supported by a German study the very next month in April. We were fortunate to have received Federal Recovery Act and New York State grants, which enabled us to purchase patient and provider stations for research purposes. We are using this equipment to conduct our latest post-home care study. The primary care outcomes in our latest post-home care study funded by Verizon are rate of hospitalization. Are patients that receive telehealth management hospitalized at a lower rate than those that receive standard of care? What about ER utilization? Do they use the ER less if they're on telehealth? Time until first hospitalization. Do we actually decrease the time it takes for hospitalization? And if we do, is the length of stay shorter? Payer costs. Are we actually saving significant dollars by utilizing this technology by avoiding hospital admissions? And then we also want to look at upload frequency. Do patients that are using this equipment actually upload the way that they should? We ask them to upload once a day, and we want to look at how often they're really doing it. Our analysis periods are 6 months. We're actually following, in this new study, we're following patients for 6 months. The last study was 3 months, so we want to go longer and see if we continue to have the same kind of results. And we're also looking at 1 month because, as you'll see shortly, 30-day readmissions are really important in healthcare today. In terms of our analytical methods, there are two approaches. One is ITT, or intention to treat analysis, where we look at everybody regardless of whether or not they're hospitalized. And then we also look at hospitalized patients only to try to understand what predicts hospitalization. So we have some preliminary results. It's still early, but we are excited to see that our data show that the telehealth and control groups are remarkably similar at start of care. In essence, it shows that randomization works. If you look at the left column, that's our telehealth group. If you look at the right column, that's our control group. And as you can see, the average age of both groups is about 85, with an age range of 70 to mid-90s. The majority of these patients are female. And the SIRS-G score stands for a Cumulative Illness Rating Scale for Geriatrics. That's a validated tool that tells us how ill the patient is based on how many things they have going on. You know, do they have diabetes too? Do they have COPD? And how sick they are. And as you can see, most of the patients scaled as a 5, the majority of them, which indicates that these patients are all very sick. Finally, their heart class scores, which indicate how their disease is impacting their functionality, were also highly similar between the groups. And again, it's telling us that the groups are the same before intervention. Okay, so what are our actual results? What's happening with emergency room visits? When you look at the emergency room visits, you can see that the telehealth intervention group has an average rate of 0.12 per 100 days, and the control group has an average rate of 0.53. If you think about this in terms of a rate, which is adjusted for the number of days on study, it's telling us that the control group is utilizing the ER at almost 5 times the rate of the telehealth group. Now let's look at hospitalizations. Similarly, when you look at hospitalizations, these are occurring at about twice the rate in the control group as compared to the telehealth group. The telehealth group's average per 100 days is 0.27. The control group's average is 0.47. It's really important to think about this as a rate because it is adjusted for number of days in observation. And this may not be as meaningful to you, these numbers, so to just put it in real terms, an average congestive heart failure hospitalization in this area costs about $22,000. So to avoid half of them is a lot of money. We also want to look at how often do patients use this technology, how often do they upload. And what we find is that the average number of upload every 10 days is 3.5. So although we ask them to do it every day, they do it about 2.5 times a week in reality, which is actually pretty good. Our future analysis is going to look at cost in some detail. We did this in our last study. It's very time consuming. We go in and look at every hospitalization, how many days they were there, what the costs were in real dollars, and so that we can understand what the days in hospitals are and what the expenditures in the hospital is. But just to give you an example of what we anticipate, in our last study, over a 90-day period, telehealth patients cost Medicare $12,000 in hospital expenditures, while controls cost Medicare $21,000 when they were hospitalized. We think that the ability of this technology to detect an exacerbation earlier means that they're in better shape when they arrive in the hospital and require less intervention in the hospital in order to be stabilized and discharged. Now, there are 2 reasons why this study is especially relevant at this point in the history of chronic disease. The first is the passage of the Patient Protection and Affordable Care Act in March 2010, which gives CMS the ability to penalize hospitals for excess heart failure readmission rates within the next year, starting with a 1% penalty payment in 2013 and up to 3% in 2015. And this is really important loss to the hospitals because heart failure is the #1 reason why people are hospitalized. And everybody's scrambling to try to figure out how to keep patients out of the hospital. The second reason why this is so important to conduct now is that the telehealth literature is literally all over the place. Some studies say that telehealth is ineffective. Others say that telehealth improves quality of life, decreases hospitalizations, and saves a lot of money. We think we know why the literature is so inconsistent. We are still in the infancy stage of understanding the power of this technology and think that telehealth should be thought of the same way that we think about medications. With medications, dosage matters, just as the level of technology matters. If you give an 85-year-old person a telephone system where they're told to press 1 if they're having difficulty breathing, that's not the same thing as having an interactive live visit with a clinician. Similarly, type of drug matters. You may not get the same results in heart failure as you get in diabetes. Timing matters. Like a drug, how often telehealth is used really makes a difference. If you give too little of a drug dose, it won't have the desired effect. Same with telehealth. As with a drug, if you wait too long, it won't have the desired effect. It won't pick up the exacerbation early enough so that we can do something about it and avoid the hospitalization. We think that with telehealth technology, if given to people at the right time in their disease and in a way that is cost-effective, telehealth can greatly improve quality of life, and we think that in the next year, with Verizon's help, we'll be able to prove it. Okay, I'll take any questions now. Okay, We have a question. Do patients like using this technology? The answer is it depends on when you ask the question. When patients first start off, they're scared of it. They don't want it. And once they've been using this for a while and seeing how it helps them, they love it and they don't want it taken out of their homes. Okay, next question. What are the issues with cognitively impaired patients? So we try very hard in the study group not to enroll patients with cognitive impairment. However, if a patient has a caregiver who's able to help them manage the peripheral, so there's a stethoscope attached, for example, then we can use this technology with cognitively impaired patients. We have another question. How costly is this technology? Between the cost of the actual computers as well as the cost of time of the clinician, we say it probably cost about $1,000 for a 6-month period. And if you compare that to the savings of one hospitalization, which is in the $20,000 range, it's extremely cost effective if we can do this right and if it's used correctly. We have a question, why is there such variation in study results from study to study? I think I talked a little bit about this at the end of the presentation. It all depends on what you're looking at. Telehealth is not one thing, just as you have to think about a diabetes medication not being the same as a heart failure medication. You would never switch them. I think the approach in telehealth has to be different for different patients with different diseases and even different characteristics of patients. So I think that's why there's such variation. And I think when you do this, whether you look at patients who are actively in home care or whether you look at patients who are post-home care, really makes a difference because your standard of care changes. Okay, we have another question here. Are there special skills needed to work in this field? It all depends on what it is you're doing. If you're a clinician, you would be trained just as any other clinician. You would be either a cardiologist, or you would be a primary care physician, or you would be a nurse or a nurse practitioner, and you would learn this skill set to be able to utilize it. It's really not complicated, and it can be learned in a few hours. Okay, another question. Do patients understand how to use the technology? Not right off. We have to meet with the patients. We actually have an installer go into the home of the patient and teach the patient how to use it. Their nurse usually comes and practices with them once before they start using it again. And I have to say that because the technology is so friendly and so easy to use, and there is, a component which involves a virtual visit where the patient can see the clinician and the clinician can see the patient. The clinician can say, oh, Mrs. Jones, could you pick up the stethoscope and move it a little bit to your left? That's right. So it's not something that they're all alone on. Okay. Is it covered by Medicare and Medicaid? Not particularly. In some states, in some instances, yes, and in many, no. Again, I say that this technology is in its stage of infancy, and we're just starting to learn what is covered. It all depends on whether you're on home care, whether you're not on home care, whether this is being done out of a cardiology office or a primary care office. So there's a lot of variables as to whether or not it's covered. Okay, another question, is it covered by other insurance? I think part of what's happening here is that these larger studies that are coming out that are showing how effective this can be will facilitate that coverage. It is covered by some insurance, but not most at this point. Have any other questions? Oh, how important, this is a great question. How important is this approach in public health given the aging of the baby boomers? I can't tell you how important this approach is. We're just not going to have enough clinicians to meet the needs of a patient. So for example, in the home care setting, think about what it costs to send a nurse in a car to drive from point A to point B, especially in an area of Long Island where it may not be close. Park the car. If they live in an apartment house, to go upstairs, access the patient, and start the visit. With telehealth, both patient and clinician knows that at 10 o'clock is the visit, and at 10 o'clock they press a button, and you say, good morning, Mr. Jones. So that's why it's very important, because there's going to be there's going to be a 400% increase in the over 85 population by the year 2030. And we need to be able to deal with huge numbers of aging adults. and we have to do it in a cost-effective way. And this constant hospitalization route is not going to cut it in the future. Okay, we have another question. Overall, will this technology save money and save lives? Save money for sure. And I think increase quality of life, yes. I think save lives, congestive heart failure is a chronic illness. People do live with it for a long time and usually die from it or a related illness. But I can say that it does improve quality of life greatly, and I think it slows the disease trajectory significantly so that people's lives are really improved. And we have another question, which is, are public health agencies embracing this approach? I have to tell you that funding for my first study came from the State Health Department, and they wanted to know more about it just to see how it works and et cetera. So yes, they are starting to embrace it, but it's taking time. And one more question, for how long has this technology existed? Remember that telehealth is everything from, a phone conversation between clinicians to something really high-tech. What I'm talking about here, this equipment in this situation has existed for about 5 or 6 years now. So it's very early days still. Do we have any other questions? If you want more information on the MPH programs at Hofstra, please go to www.hofstra.edu/public health. Thank you for your time, and have a good day.